Next is Dr. Divya Alex, our course coordinator, working as a VR consultant in Ahilya Hospital. Over to you, Dr. Divya.
So, a warm good evening, everyone. So, we live in the era of MIFs or mix. Everything is minimally invasive. So, this gives or provides us the cutting edge care where we get a faster, safer, or better result, better visual outcomes for millions that lives in the world. But imagine your post-operative outcome is something like this. It can happen and it is scary. So we have to understand that even in the most advanced minimally invasive surgery, there occurs a minimal amount of normal postoperative inflammation that has been studied with laser flare photometry. This starts in the immediate postoperative period with a mild anterior chamber reaction and it peaks in the day 1 or 3. And with appropriate steroid coverage, this will come to a complete resolution with no trace of anterior chamber reaction in a week 2 or 3. This is the normal inflammatory response. So any excessive early inflammation, any inflammation worsening after an initial improvement, any inflammation that is persistent beyond 4 weeks, or any inflammation that is associated with pain or vision loss should be dealt with caution. So the inflammatory cascade stems from the disruption of the blood-aqueous barrier. It can be secondary to an even iris touch or an iris manipulation, your IOL insertion or the surgical trauma. And especially in patients with diabetes, they will have an exaggerated response due to immune-mediated reaction. So what all we are dealing with? These are the most common conditions: the non-infectious uveitis, the TARS, the infectious endophthalmitis, and less commonly the retained lens material. So the mild acute anterior uveitis or the iritis, this is the most common scenario you come across in the OPD. This is the post-operative patient that presents with cells and flare post-op. So 98% of this will be well controlled with a good steroid regimen. But the problem occurs when there is a rebound iritis. Rebound iritis is the recurrent anterior chamber inflammation that develops after an initial postoperative resolution. The most common underlying mechanism being a premature or overly aggressive steroid reduction. So what do? You treat them with topical corticosteroid. Pred-acetate 1% remains the first line therapy any day preferred over the dexamethasone. And continue the cycloplegic therapy until the anterior chamber cell reaction, it is less than 0.5 plus grade on grading. And this is any rebound iritis, this should not be your blind 4-3-2-1 regimen. You should monitor and observe closely until fewer than 5 cells per HPF are observed. So even with your appropriate steroid therapy, there can be patients waiting multiple episodes of rebound therapy. So in that, you can use enhanced delivery systems like subconjunctival triamcinolone or sustained release technology such as dexamethasone intracanalicular insert. But unfortunately, this is not available in India. But there has been studies proven that your Osudex, the Dex implant, can manage the recurrent episodes of rebound iritis. Next is the retained lens matter postoperative inflammation. So it can be your loosey, fluffy cortical material or the nuclear fragments. So these patients usually present with persistent anterior chamber reaction with KPs and elevated IOP. Sometimes we have to use UBM or ASOCT for this recurrent anterior chamber reaction. Sometimes it may not be seen in the AC. It may be clogged in the meshwork. So your fluffy cortex material, it causes only a low-grade manageable inflammation that may respond well to your corticosteroids. But if it is a nuclear fragment, it can trigger intense phacoantigenic reaction. This almost always require a surgical removal. Next comes the toxic anterior segment syndrome, which you call as the TAS. What is TAS? It is a non-infectious, sterile, inflammatory response which is triggered by surgical contaminants. It has got a hyperacute onset. That means that it occurs immediate postoperative period. Within 12 to 48 hours, this will be there. So it occurs as a toxic insult secondary to the contaminated solution. It can occur from any preservatives or the ophthalmic viscose or the ringer lactide solution, any inoculum that enter the anterior chamber. So this triggers an inflammatory cascade, and this causes a widespread damage of the corneal endothelium that is causing your limbus to limbus corneal edema. This can damage your iris cells that is causing intense AC reaction. This can damage your trabecular meshwork causing a secondary IOP. So these are the features: the limbus to limbus corneal edema, and severe anterior chamber reaction will be there. And do you get hypopyon with TAS? Yes, you can get, but it will be sterile, it will be sticky, a kind of non-mobile hypopyon. And the hallmark sign, it is the limbus to limbus corneal edema because of the widespread damage of the corneal endothelial cells. And the most important factor is differentiating TAS from the infectious endophthalmitis. So as I said, once it is the hyperacute presentation, one it is the limbus to limbus corneal edema. The other thing, the pain, the circumcorneal congestion, the hypopyon, anything can happen with a permutation and combination. So you can't rely on that. But you have to understand that TAS is something confined to the anterior segment. So the vitreous will be very clear. There won't be any vitritis. So how do you treat a TAS? The cornerstone is the intensive anti-inflammatory treatment, half-hourly or hourly prednisolone treatment, and with close monitoring and with aggressive IOP management. And if it is TAS, it will automatically improve with your treatment. But even with your maximal medical therapy, there are some refractory cases. And in those cases, we may have to do an AC washout. You use a TPA for fibrin dissolution. And sometimes if IOL is the source of toxicity, you may have to do a lens exchange. And here comes the postoperative endophthalmitis. Even if we are going through the safest era of MIFS and MICS, we get an incidence of 0.1 to 0.2% of post-cataract endophthalmitis, and clear corneal incision have increased these numbers, but I do believe that there are many cases of underreporting. There may be the fear of litigation or the gaps in the surveillance or mainly diagnostic complexity, because there are a lot of atypical presentation that can mimic an end of. So what are the features? Usually the onset is typically between 3 to 7 days post surgery, but as I said, any combination can happen. It depends on the virulence of the organism and the size of the inoculum. And blurred vision, most common symptom, and 25% of the patients will be presenting with the perception of light or worse. And there can be circumcorneal congestion, ocular pain, but only in 75%. Notably, 25% can present without pain. So the key factor is the vitreous involvement. So there will be vitritis, there will be media haze, and B-scan, there will be showing vitreous opacities and multiple membranes. So the traditional management was like intravitreal antibiotics, and vitrectomy was reserved only for patients with light perception. But as I said, we live in the era of modern vitrectomy. So now it is the era towards the prompt vitrectomy. It helps in the early debris removal of the infectious organism, the inflammatory mediators, and the toxin. And we do use combined approach also. So we have done 38 cases with the combined approach, and this has given like a huge good visual impact on the patients. This was a pre-operative patient with hand movements vision, status post intravitreal antibiotics and prompt vitrectomy. Vision improved to 6/9, and these are some of the representative cases: pre-operative fundus photo and the post-operative fundus photo and the OCT with our combined approach. So as managing the cataract in an OPD, when immediate referral is mandatory, anything that is not under your control. So you are treating if there is a persistent anterior chamber reaction. If anything that is suspected to be an endophthalmitis, timing is the key. There should not be any hesitation in referring. You should refer and make the patient understand. Sometimes there can be some intraocular foreign bodies like some cotton fibers or suture material that can be leading to persistent anterior chamber reaction. That also referral. And any refractory elevated IOP or retinal detachment sign, mandatory referral is needed. And refer without hesitation. As I told, timing is the key, and you should have a strong VR team in your hand, like somebody to call and immediately refer. That is how you can save the vision of the patient. So thank you, and I thank KSOS and everyone who attended and my esteemed panel to make this IC a success. Thank you.
Thank you, Divya. Thank you for the nice talk. One more additional thing I just want to add to Dr. Divya's talk, which is very excellently given. See, nowadays, of all the anterior segment specialists, and most of the ophthalmologists are giving intravitreal anti-VEGF injections. So they are very accustomed to give intravitreal anti-VEGF injections. So if you suspect in early post-op period that there is a chance of end-off is there, there's inflammation is more than usual, And if you are finding that patient is not going straight away to your referring doctor, at least try to give one shot of intravitreal antibiotic. It is never going to harm the patient. It might precipitation might cause minimal blurring for 1 or 2 days, but it is never ever going to harm the patient at any cost. So if that will anyway give us a lot of good window period for better improvement and early intervention for the patient who is endemic into endophthalmitis. So that will be my message to you all.
Yeah, excellent point, sir. And there is nothing much to think because your Aravind team has come with an e-kit, so endophthalmitis kit. Every instruction is very clear. 2 injection will not harm the patient. It will always benefit the patient, even if you are in doubt.